This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending in Pediatric Neurosurgery.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It focuses on a very specific, high-stakes clinical challenge: how to deliver intrathecal chemotherapy effectively to children who have both high-grade CNS tumors and shunted hydrocephalus.
This is a classic dilemma in our field, Alara. We have these infants and young children with embryonal tumors, things like medulloblastoma or atypical rhabdoid teratoid tumors, or ATRTs. These patients often present with obstructive hydrocephalus that requires a ventriculoperitoneal (VP) shunt, but their oncological protocols, like the ones for high-risk, high-grade tumors, also mandate direct administration of chemotherapy into the ventricular system.
Exactly. And the problem is that if you have a standard shunt, the drug you just injected doesn't stay where it's supposed to. Some of the medications, whether it's methotrexate, Ara-C, topotecan, or hydrocortisone, will inevitably drift down to the abdomen.
Right. It drains through the shunt, which means you're getting subtherapeutic levels in the CSF and potentially unnecessary systemic exposure in the peritoneal cavity. Historically, we've tried to solve this with Ommaya reservoirs or lumbar punctures, but as this paper points out, having both an Ommaya and a shunt is more hardware and more surgery. This study looks at using the programmable valve itself as the port.
It's an international multi-center retrospective study involving 3 major centers: Dana Children's Hospital in Tel Aviv, Charité in Berlin, and the University Children's Hospital of Basel. They looked at 18 children, up to 16 years of age, though the mean age was quite young, only 5 years old.
Let's talk about the hardware they used, because the virtual off setting is the key here. They used 2 specific types of valves: the Codeman Certus Plus small programmable valve and the Meath-K ProGav.
Right. For the listeners who use the Certus Plus, you know it has 8 settings. The first 7 are standard opening pressures ranging from 25 to 215 millimeters H2O. But it's that 8th setting, the virtual off, that this study utilizes. It sets the opening pressure to 400 millimeters H2O.
And for the ProGav users, it's a bit different. That valve has a programmable component and a gravitational unit. It doesn't have a labeled virtual off, but at its highest setting, the resistance is 200 millimeters H2O when the patient is lying down and up to 500 millimeters H2O when they are standing. In those cases, they added a burr-hole pre-chamber reservoir.
The critical anatomical point the authors make is that for both valves, the reservoir is placed proximal to the valve mechanism. Since there's no unidirectional component between the reservoir and the ventricular catheter, there's minimal resistance for the drug to reach the ventricle when you inject. When the valve is set to that virtual off or maximal pressure, the chemo is anticipated to reach the ventricle and stay there, rather than moving to the distal component of the shunt.
Let's walk through the procedure they described. It's quite methodical. First, they shaved and prepped the skin over the reservoir. They used a small gauge butterfly needle, usually 23 or 25 gauge, to tap the reservoir. They would aspirate a few cc's of CSF for labs, then slowly inject the chemotherapy.
And here is where the programming happens. Before the injection, they use the external magnetic device to switch the valve to the virtual off setting, or the highest possible pressure.
And they didn't just flip it back immediately. The paper mentions that the valve was kept at this virtual off setting for a period of 1 to 4 hours after the injection. The specific duration depended on the center's protocol and how well the child tolerated it. After that window, they'd reset the valve to its original clinical setting.
It's a clever way to lock the drug in the CNS during that peak distribution window. Looking at the results, these 18 children underwent a total of 17 plus or minus 14 injections each. Some patients had as few as 3, but one patient had up to 55 intrathecal injections through the valve.
That's a high volume of access, and the safety profile they reported is actually quite impressive. They had 0 infections, no leaks, and no major surgical complications.
There were a few minor issues, though. One child required a wound revision because the proximal catheter became exposed due to extremely thin skin. Another patient experienced a stuck valve setting, but perhaps the most important one for residents to look out for is the one patient who developed symptomatic hydrocephalus during the injection period.
That makes sense. If you effectively turn off the shunt for 4 hours in a child who is truly shunt dependent, you're gambling with their intracranial pressure. In that specific case, the symptoms resolved as soon as the valve was reset to its baseline pressure. It emphasizes the need for close monitoring during that 1 to 4 hour window.
Absolutely. But despite those risks, the long-term outcomes were encouraging. 8 of the children are alive with no active disease, with a mean follow-up of 52 months. And crucially, the authors noted no late effects related to the intrathecal chemotherapy itself.
This study really challenges the need for an additional ventricular access device like an Ommaya reservoir in these specific patients. If a child already needs a VP shunt for their medulloblastoma or ATRT, why put them through a second procedure for an Ommaya if the programmable valve can do both?
Exactly. The paper explicitly states that this technique obviates the need for an additional ventricular access device. It simplifies the surgical management of a very complex patient population.
Now, for the residents listening, we should highlight the limitations. This was a retrospective study with a small sample size, only 18 patients, and while the virtual offsetting at 400 millimeters H2O is high, it's not a physical closure, it's an opening pressure. If the child's ICP exceeds 400, the valve will still open.
True, but as the authors suggest, that's actually a safety feature. It prevents the ICP from reaching truly dangerous levels, while still being high enough to prevent the drift of the medication to the peritoneum.
It's a virtual off, not a mechanical off. That's an important distinction. The authors also touched on the fact that these valves, the Certus Plus and the ProGav, are designed to withstand unintended setting changes from external magnets up to 3 Tesla. That's vital because these kids are in and out of the MRI suite constantly for tumor surveillance.
We should also mention the pathologies again. 7 patients had medulloblastomas and 5 had ATRTs. These are the high-risk embryonal tumors where IT chemotherapy is most often indicated. The fact that they could deliver these toxic agents through the shunt reservoir without skin breakdown or infection over dozens of cycles is a big win for the patient's quality of life.
It really is. It reduces the surgical burden on these kids who are already going through resection, radiation, and systemic chemo.
To summarize for our listeners, the study concludes that programmable VP valves with a virtual off or high pressure setting are a safe and effective method for intraventricular chemotherapy delivery. It allows for higher drug concentrations by temporarily decreasing CSF drainage, and it avoids the need for a separate Ommaya reservoir.
It's a great example of using the technology we already have in the OR, programmable valves, to solve a secondary problem in oncology. Just remember to monitor those patients closely while that valve is set to 400 millimeters H2O. You don't want to trade a successful chemo dose for an acute hydrocephalus crisis.
Well said, Dr. Aris. This study is a great reminder of how neurosurgical innovation often comes down to how we utilize our existing tools more effectively.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
We'll link the full study in the show notes. See you next time.